are you doing? Long
I'm
time.
good. How are you?
Good. I feel like people probably don't know that I talk to Dr. Zoland maybe once a week or once every other week about all of our patients. Um, and I probably say his name once a day at minimum to patients that I want him to see to help me figure out whether they have a hernia or not. So hold on one second. I was going to do my little introduction. Dr. Zoland graduated from Columbia. He's a surgeon. I mean, he's been doing this stuff. I remember when you told me for your 50th birthday present, you started only doing hernias. And he's been doing this for a really long time. And so anytime I have a patient with pelvic pain, I always refer to Dr. Zoland. So why don't we just get right into it, because I know we have a ton of questions and people are going to want to hear as much from you as possible. Tell us how patients can have hernias and also have pelvic pain and how they're connected.
Right. So let's start by talking about what is a hernia. A hernia is an opening where something is pushing through the muscular layer. The openings start by weak spots in the abdominal wall or the pelvic floor, and the weak spots are generally because structures go through them. Structures like nerves, blood vessels. The inguinal hernia is a typical example where in the female, the round ligament goes through the internal ring, and the internal ring is just an opening on the inside of the abdominal cavity that lets a structure go through it. So the structure in the female is the round ligament, and if something else pushes through where that round ligament is, where that potential weak point is, that is a hernia. So the muscular wall opens up. And hernias, there are multiple hernias. Hernias can be essentially anywhere in the abdominal wall, but the typical, and the pelvic floor. When I say abdominal wall, I mean any of the muscular structure that is the muscle structure that makes up all of the abdominal cavity. So the bottom of the abdominal cavity is the pelvic floor, and the front of it is the abdominal wall that we think about, rectus muscles, obliques. And then you've got your diaphragm, and you can have diaphragmatic hernias. And then the back, and the back is much more powerful, bigger muscle structure. And you can have hernias there, but it's very, very uncommon. But your typical hernias are the umbilical hernia, i.e. the belly button hernia, the inguinal hernias, which are more common in men than in women, but women can certainly have them, and the femoral and obturator hernias, where we're starting to get into the real pelvic floor hernias that we do see and that can cause real pelvic floor symptoms. So in the obturator hernia, that starts as a weak point because the obturator artery and vein and nerve go through the obturator canal, and that's right at the front of the obturator internus muscle, which anybody who deals with pelvic floor pain, or any of you pelvic floor PTs who, by the way, kudos to you. I love you guys. I think you guys are fabulous. Special place in my heart for all pelvic floor PTs. But the obturator internus is something that you guys know intimately well, and anybody who's had, unfortunately, if you've been subject to having pelvic floor pain, I'm sure you've come across the obturator internus. At the very front of it is the opening for the obturator nerve, artery, and vein, and if that opens up and something pushes through, usually it's some fatty tissue, but it could be something else, then you have a hernia in the obturator canal called an obturator hernia, and this technically is a hernia in the pelvic floor. A little bit higher up is the femoral canal. You can have a femoral hernia, which is going down into the leg, and then a little bit higher up is, like we talked about a second ago, the inguinal hernia, just a little bit above the groin crease where you would see the bulge, or sometimes you don't see the bulge, and we can get into that. But the simple point is that a hernia is an opening in any one of these spaces, and it usually develops because of a weak spot, and we can get into the reasons why hernias develop in some and not others. But the point is that hernia can irritate the structures. It can irritate the nerve, or it could just irritate the musculature, because anything pushing through a muscle that's not supposed to be there might make the muscle go into spasm. And as most of you who have unfortunately had these issues, or even if you haven't had pelvic floor issues, you know what a muscle spasm is. Most people have had that, and it's not fun. And if it's happening in the pelvic floor, if it's happening in the inguinal canal, it just doesn't feel good. So At the end of the day, hernias can be very, very symptomatic, or they don't have to be symptomatic at all. They don't have to have symptoms. And that'll lead to the question, well, how do you know you have a hernia? And we'll get into that. But let me just stop there for a second. Tay, was that a decent explanation?
Yeah, no, 100%. So basically, just to reiterate, there are multiple different types of hernias. Ilioinguinal hernias are the most common, it seems. Would you agree?
I didn't hear
inguinal hernias are the most common.
In males, inguinal hernias are the most common.
And what about in females?
In females, usually it's the umbilical hernia, and a lot of that has to do with having had a pregnancy. It stretches the abdominal wall. But, you know, we are finding inguinal hernias more and more commonly in females. And a lot of times, let's just go through the inguinal hernia symptoms, because I think this is an important point. Inguinal hernias in males cause pain oftentimes down to the testicles. So your typical situation is your 25-year-old was lifting, felt a little pop, and all of a sudden started having a lot of testicular pain, and they run in worried that they have testicular cancer.
So can you have, just so we're going to talk really layman's here, if your left side inguinal canal is hurting and you hear a pop, can your right side testicle hurt from that?
Generally, no. If there's only a hernia on one side, you're going to have the pain on that one side.
Okay.
And
a lot of people don't get that there's not just one hernia. Everything is symmetric on your body.
That's right.
So, yeah.
That's right. So so the inguinal canal is the space just above the groin crease, and the groin crease is the spot where the leg meets the body. So where the leg meets the body, everybody knows, is that line that, you know, when you sit down, that's your groin crease. And just above that, in males and females, are the inguinal canals on either side. And in the male, you can have pain from a hernia on that one side down to the testicle on that side. So if you have a left inguinal hernia, it's left testicular pain. A lot of people have bilateral, meaning both side hernias at the same time. Oftentimes there's only going to be one side that actually causes pain. And the analogous pain that a female will feel is pain to the labia, pain to the inner thigh, pain to the groin crease, sometimes what may feel like bladder pain, pain to the lower abdomen, or even pain all the way up to the belly button coming from one side or the other side. So that could be hernia pain in a female. So number one, myth that females don't get inguinal hernias is untrue. They do. It's not the most common hernia that they get, but any groin pain that a female has, you need to make sure it's not an inguinal hernia, because it certainly could be. Now, the most common hernia in a female is going to be the umbilical hernia. Anybody that has an outie belly button is not a real thing. An outie belly button actually is a small hernia, and that outie can grow or it may not grow. You may have had it since you were born, and it's just there and it stays the same, and you can just leave it alone. But if you have something that went from an innie to an outie, it's progressing. There's a hernia that is progressing. If it doesn't cause any pain and it's small, we leave them alone. But a belly button hernia would cause pain around the umbilicus being the belly button, or it could cause midline pain down to kind of the pubic bone. So that would be an umbilical hernia.
I need to send my husband to you, because I'm pretty sure his belly button is starting to get necrotic, and he needs to get his umbilicus checked. He's just too busy.
Actually, just bring him over here and just lift up his shirt on Instagram Live in front of all the people. That'd be perfect.
He's at work.
Okay.
But yeah, so yeah, it's a really interesting point. So in the realm of pelvic pain, do you see a lot of umbilical hernias, or is it mostly other type of hernias? It's
mostly other types of hernias. And quite frankly, the umbilical hernia is the one that's the most obvious. That's an easy one to usually diagnose, and you don't have to go through the whole rigmarole of doing a whole bunch of tests. Whereas the inguinal hernia, and especially the femoral and the obturator hernias, are much, much harder to diagnose, especially on a female. The physical exam to figure out if there's a hernia or not is very difficult. So
that brings us to the question the PT asked, a quick assessment, and yeah. How would you do a quick assessment?
Gotcha. So quick assessment, the most important part of the assessment, quite frankly, are the symptoms and the history. In other words, what are you feeling? Okay, you're feeling pain, and your pain is to your right labia. Okay, that could be a pelvic floor problem, but does it get worse with working out? Does it get worse with standing? Does it get better when you lie down? Hernias are based upon gravity. So if you go to lie down, you feel better, versus other problems that people have oftentimes don't feel better when you lie down. But hernias are generally positional, unless they're stuck. If there's a stuck hernia, it doesn't matter what you do, you're in a lot of pain. But that being the case, the symptoms.
And when you say stuck, you mean like?
Yeah, so a hernia, so Dr. Ahmed is bringing this point up because this is a really important point. Hernias are generally fine. They don't bother anybody unless they're causing a little bit of pain, but they every once in a while could get dangerous. And the danger part comes from something pushing through the opening and getting stuck, because there's enough intra-abdominal pressure pushing something, and that something could be some fatty tissue. It could be some bowel being the intestines. It could be an ovary. It could be an appendix. So something can push into the hernia and can get stuck. So if you feel like, hey, I've had a hernia all these years, it never bothered me, and then all of a sudden there was a dramatic change, or if you never really felt anything, and all of a sudden you have pain in these deep areas that we're talking about, and the pain is constant, and it's severe, or even a little bit less than severe, do not wait around and just say it'll go away. Run over to the emergency room, or at least speak with your doctor, because if you have a hernia that's stuck, and the term for that we use is incarcerated. If there is a loop of bowel that's incarcerated in a hernia, that is dangerous. And in that setting, we're going to have to do something, whether it's push it back in, or get a scan, or run to the operating room. So there's a time frame that you need to be aware of, that if something is stuck, it could, and this is the word you used before about your husband. I'm sure this isn't the case that he has necrosis, but necrosis is when the tissue that's stuck in the hernia starts to die. And that becomes a real surgical emergency. And the simple fact is, nobody wants to be in that position.
Yeah. Okay. So I hope that answers the question about quick exam, understanding.
Right. So, okay, but yeah, sorry to interrupt, but let's finish that point, because this is really good information. So you start with your history, and the pain tends to radiate. It starts in the internal ring, and it kind of radiates down towards the groin crease, or down towards the labia. And it gets worse as the day goes on. And then when you do the physical exam, if you map out where the internal ring is, and you should be able to do that from anatomy books and what have you, it's generally pretty tender there, especially if somebody's at the end of the day, or they've been working out and they've annoyed it. So a typical thing that'll happen is, after I examine somebody for a hernia, they say to me, it's really revved up now. You really made it hurt. And I apologize, of course, but the reality is that that's a good thing. That tells me that this is a pretty good likelihood that this person has a hernia, because pushing on your lower abdominal wall, or your femoral canal, which is just below the groin crease where your femoral vessels are, shouldn't end up hurting somebody so much. But if you have a hernia there, you're mashing on the hernia, which is pushing on the nerves around it, or pushing on the muscle tissue, and it's going to hurt them. The other thing that you do during the physical exam is you have people stand up, you put your fingertips, 1 or 2 fingertips, right in the area where that internal ring is, and you have them cough. And if it's not easy to figure out that there's something pushing through the canal, and that pushing through is kind of like the sliding sensation, versus when you have somebody cough and you feel an impulse. Everybody has an impulse. There's this impulse that happens when you cough, but there's a sliding sensation underneath your fingertips when you have a hernia. So if you feel that on one side that they're having pain, and you don't feel that on the other side, that's a pretty good bet that that's a hernia as well. But again, in a female, it's not an easy exam, even for me, to be clear that somebody has a hernia or does not. And that's what brings me oftentimes to diagnostic testing. So you can get an ultrasound. Oftentimes, as you see me do, I'll get an MRI, because I just think an MRI is terrific. It's no radiation. It's very, very safe. It's a pain in the butt for the insurance companies to get the approval for it. However, it gives me a ton of information. And it shows me if there's an inguinal hernia, it shows me if there's a femoral hernia, it shows me if there's an obturator hernia. One key point here is that the MRI that we do has to be a very specific kind of MRI. It's a specific protocol. And the protocol is really important because otherwise you may not see the fat planes light up, you may not see the muscle planes light up the way you need to see them. So if you don't do it in a certain type of protocol that we use, it's possible that you'll still see it, but oftentimes they will miss the critical views and the critical images that we need to see. Once we diagnose hernias on the imaging, it doesn't mean we have to fix them. If they're the source of pain, it's worth fixing. If they're potentially dangerous, meaning if there's already bowel in it, it's definitely needing to be fixed. But if there are small, little fat-containing hernias that don't bother the patients, there's no reason to fix them. So the real question is, does somebody have a hernia? And historically, is the hernia irritating them? And most importantly, do we think that the irritation that they're feeling is from the hernia, and therefore is it worth fixing? Sometimes you're not sure, but you go through that algorithm to kind of figure things out.
What are the most common ways that people can get a hernia?
So generally speaking, hernias are a several factor phenomenon, like most things in medicine. Genetics, what you're doing physically is a big deal. Meaning, if you're somebody who's been chronically constipated, and so many people obviously with pelvic floor dysfunction or endometriosis or chronic prostatitis end up getting constipated, that puts a lot of pressure on the intra-abdominal wall because you're trying to generate a lot of pressure to have bowel movements, and that's pushing everything out. So what happens, the opening where the hernia is, something's trying to push out that opening because you're generating a lot of intra-abdominal pressure. But it doesn't have to be things like chronic constipation. It could be because you work out a ton, right? You decided that this is the year you're going to get the beach body, and bottom line is you work out like a lunatic, or maybe you work out just a little bit, but the point is you're creating intra-abdominal pressure. You're not breathing as much as you should while you're working out. Maybe you are, and maybe it's just bad luck. Maybe genetically you have stretchier tissue, and hernias develop because of that. Hernias often run in families, which is interesting, and half the time you tell somebody that they have a hernia, and then they get back to you, the next time, and they say, my dad and my aunt and blah, 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 they all had hernias. So bottom line is it's fairly common that it runs genetically in families.
So I see a lot of our patients, when we ask about history of hernias, they'll say, oh, I had a hernia, or I had something when I was a kid, or I had something when I was, 17 years old or something. And that was like 30 years ago. And they don't remember if they had mesh or something placed. What do you do in a scenario like that, where someone says they have this history of having a hernia repaired already, but I can't possibly have another hernia? What do you say to that?
Well, certainly hernias can recur. There's a recurrence rate to all hernia surgery. And especially if you had a hernia when you were a child, there's a fairly decent chance that you could have a recurrence of the hernia. So anybody that's had a prior hernia, you have to have a decent level of suspicion. But at the end of the day, the proof will be in the pudding, meaning it'll be on the MRI or it'll be on the scan that there is a recurrence of the hernia. So the nice part about it is we try not to have very much guesswork here. We try to scan almost everybody, especially if it's unclear where the pain source is coming from. But the critical element is, again, you get the right kind of scan, and then the secondary element, which is a real fly in the ointment, so to speak, is that not all radiologists are the same when it comes to reading for hernias.
Yeah.
So unfortunately, I end up reading, I don't know, maybe 4 or 5 scans every week for people, just because they want to know that they definitively don't have a hernia, or did the radiologist misread it. And it's not technically a misread. They have a slightly different definition of what a hernia is. They're incorrect, of course, but that's the reality. That's they've been trained that way. So
can you just put that out there? So, because I'm going to end up putting this on YouTube, and whenever I want to tell a patient, I'm just going to tell them to come back here. Can you explain why a radiologist might read it as a totally normal image and
Right.
why
Right.
why this changes throughout the country. I mean, even the world. Yeah.
So there's a couple things that happened in the development of radiology. Number one, MRIs became amazingly detailed, and you're able to delineate fat planes really, really well. And what happened was that the definition for a radiologist of a hernia was that it had to be some intra-abdominal organ going into the canal or into the opening. So essentially their definition of a hernia is only intestine or only ovary or appendix or something coming from the intra-abdominal cavity. However, that doesn't make sense in the grand scheme because 95% of hernias are fat only. So the general surgeon, on the other hand, doesn't care what goes in the opening. We just care that there's an opening. What does it matter if it's fat or intestine going through that's irritating the nerve and causing pain? Just because it's fatty tissue causing pain doesn't mean it's not a hernia. It doesn't mean that there isn't the opening. So because the radiologists were definitionally taught that fat, you can't call a fat-containing hernia a hernia, they may just not mention it. And then when you speak to radiologists and you say, well, don't you see that there's a whole bunch of fat in the inguinal canal? They say, well, yeah, I see that there's fat in the canal, but, that's not necessarily a hernia. And my contention is, well, where did the fat come from? It had to come through an opening from somewhere. There has to be an opening. The opening is the hernia. That's the definition of a hernia. So it's this back and forth, but we're working on educating radiologists. We are trying to write papers. We are trying to be very vocal about this because, people walk around with a report from a scan that says no hernia seen. And once they have that, no surgeon wants to touch that. Surgeons say, oh, well, you have this radiology exam and there's no hernia there, so you don't have a hernia. But unless the surgeon teaches themselves or finds somebody to teach them how to read these scans, they're not going to make a difference. So that's another problem that you probably want. If you suspect that you have a hernia, either send me your scan and I'm happy to look at it, or go to the local university setting and find a hernia surgeon who reads their own scans. If you bring a scan in and the hernia surgeon reads the report and says, oh, it says no hernia seen, and they do not look at your scan, this is a critical point. If your hernia surgeon or your general surgeon does not look at the scan, walk out and go to the next person. Because the reality is we should all be looking at the scans, especially when it's been estimated that radiologists misread the scans for hernias up to 65% of the time. That means more than half the time they're getting it wrong. So there's millions of people walking around with hernias with scans that say that they don't have hernias. Do not get me wrong. Not everybody needs to be fixed. I'm not saying that every hernia needs to be fixed. Again, this is a really important point. But if you're having pain and you don't assess that you have a potential hernia appropriately, you might be missing the most likely diagnosis that's causing your pain.
Well, so I think the really important thing to know is that pelvic pain is something so intimate and so private and so embarrassing for people. And when people come to me, they're often really unclear, depressed, confused, a bunch of emotions. And when I diagnose, or I maybe examine them, and then I do the imaging, and then I send out the imaging to Dr. Zoland, and he tells me they have a hernia, which I do quite often. Then I maybe diagnostically inject them, and their pain goes away. This can prevent them from having other surgeries like oophorectomies to take out their ovaries, or if they're thinking they might have leftover endo and endometriosis that could still be in there, or there's a lot of pain generators in that area. And I think the most important thing to understand is that we don't want to find a hernia, but if there is a hernia, and it could be the smallest little piece of fat, if that piece of fat is indeed what's causing your pain, removing it, which is a relatively simple procedure, and the next thing I want to talk about, then how brilliant is that little piece of fat that we can that Dr. Zoland or some hernia surgeon can remove can change. And I see this weekly. I see this like every week. So it's not like people just don't understand. Like, no, but I'm told I don't have a hernia. My primary care did an exam. I coughed. There was no hernia. Just because you don't see a bulge doesn't mean that you don't have something there. And just because the MRI, so always just getting that, getting the diagnostic injection or getting proper imaging evaluated is really important, especially when with pelvic pain, because this is such a private thing that you're probably not talking to many people about, and you can't just let it, pass because you're living with it.
And let's talk. You mentioned the diagnostic injection, and I'm a huge fan of those, but let's explain that a little bit. So if a hernia is banging on a nerve, and hernias are near a lot of these nerves that are near the ilioinguinal nerve, the genital branch of the genital femoral nerve, the iliohypogastric nerve, that's the inguinal hernias, they're near the femoral nerve. For a femoral hernia, they're near the obturator nerve. If you have a hernia, but we're still not clear that that is the source of your pain, what we can do, what Dr. Ahmed could do, for example, is she can do an ilioinguinal nerve block. And if she blocks that nerve upstream from where the hernia is hitting it, and when I mean upstream, I mean toward the spine, because you want to catch the nerve before the spot that the hernia is irritating the nerve, and she turns that nerve off and the pain goes away, it's a lot more likely that it's the inguinal hernia because it's the ilioinguinal nerve that she is injecting, or the genital nerve that she's injecting. So the point being that even if you have pain and we diagnose a hernia, it doesn't mean that that's the source of the pain. We're going to try and get a little bit tighter on that. We're going to try to diagnose whether or not it truly is the source of pain by doing this diagnostic injection. There's very little downside to doing a diagnostic injection. It's just a little bit of anesthetic, which is something that you would use at your dentist. You turn the nerve off for an hour or 3 hours or whatever it is that you use to turn the nerve off. It gives you a certain amount of time. And then it delineates for us whether or not the likelihood of the hernia is a much higher likelihood or a much lower likelihood. And that's just a really big, important point here that, it's complicated and there's a big algorithm to go through. And by no means are we always right. And by no means is it all that straightforward all the time. But if a hernia is part of the equation and it is part of the pain source, and you get rid of the hernia, it's a nice thing to get rid of that pain source relatively easily.
Yeah. So what is the process of, what's the process of a consult with you? And then what's the process of going through the whole surgery?
So I do hour consults because I really like to get, into the nitty gritty of the pain. And a lot of people come with really long stories and really big charts, and I don't want to have just 15 minutes to say, yeah, okay, let me examine you. Because again, going back to my point, even for me, the history is a huge, huge deal. And it also gives me a sense of how complicated the patient is. If they're just having straightforward pain and the pain started 6 months ago and somebody told them maybe it was their hip, but lo and behold, they went to, somebody who said, hey, maybe this is a hernia, and it turns out that they have a hernia. That's a fairly straightforward thing. And my next step would be, well, maybe let's get a sonogram or maybe let's get an MRI and just confirm it. Your story certainly sounds like that. But then you can have somebody who has had multiple surgeries, has really complicated things going on, pelvic floor dysfunction, maybe some endometriosis. And then even if I find a hernia, I'm very wary that it's not the source of pain because there's multiple sources of pain. So again, we're definitely going to image it, or I'm going to look at the images that you bring to me. And we're going to try to do some diagnostic injections, whether it's myself in the office doing it, or whether I, let Dr. Ahmed do it, or not let her, but ask her to do it because that's part of her expertise. Or a lot of the people that I work with, they have this level of expertise, and we really try and nail it down a little bit. But the point is, I'm going to spend an hour with you. I'll do the exam. I'll really try and get to the pain generators. What is it that causes your pain? Is it coming out of a car? Is it getting into a car? Is it when your leg goes outward and upward? Or is it when you lean forward? All these things are part and parcel of trying to establish, mechanically speaking, where the pain generator is coming from and what is causing it, and then trying to kind of like piece backward could this be a hernia? Is it not a hernia? Is it more likely something else? Is it your psoas muscle and your psoas is going into dysfunction, or you have bursitis, or is this really a hip thing? And I'll do the hip exam, or, you know, anything that has to do with sort of pelvic floor stuff and hip and hernias. You really want to try and hone down in as many of these directions as you can. And that's what the consult is all about, really getting a sense if this is going down that avenue, or is it just not going down that avenue? And if not, what are the other potential possibilities?
And so let's say you diagnose a hernia and now a patient wants to have surgery. What is the recovery like? When can they resume activity? What type of activity do they have to avoid,
Right.
etc.? Like,
I mean, generally speaking, hernia repairs are not that bad. They used to be pretty rough. Most of them used to be open hernia repairs. So people were laid up for a bit and they were in a lot of pain. Now we do most of these laparoscopically. And when we do them laparoscopically, there's a tiny little incision by the belly button, 2 other little puncture sites. We close the hernia by laying a mesh in the position over the gap. And this is the standard of care right now. This is the gold standard of fixing hernias in this day and age. And I hear lots of people out there saying, mesh, oh gosh, mesh, mesh. And let's talk about that in a second. But for the most part, I have you take it easy for about a week, and then you getting back to your life. And I'm having you off of sports for about a month. And then between 4 weeks and 8 weeks, you ramp up what you're doing. So if you're somebody that likes to play tennis recreationally, I don't let you go out and play tennis for that month. And then what I say to you is break up the next month so that you're advancing 25% each week. So at the end of 2 months, I'm pretty much giving you the green light to get back to what you're doing if it's a straightforward hernia. So
what happens if you have multiple hernias and if you have bilateral?
Right, so bilateral doesn't really change the equation. Multiple hernias, meaning do you have femoral hernias and obturator hernias and inguinal hernias, which some people have, all of the above. They won the lottery. At the end of the day, it doesn't really change the recovery period. If there's a belly button hernia, that changes it a little bit, because that's if you're torquing your abdominal wall, or if you have what we call a ventral hernia or an incisional hernia. These are all hernias that are higher up in the abdominal wall. That will increase the recovery period by about a month or so. So that's more like a 3-month recovery period. But for the most part, if it's just the inguinal femoral obturator hernia and you're fixing it laparoscopically with mesh, really you're out of the equation for 1 to 2 weeks. And then you're getting back to your life, you know, and you know, especially since people are working from home these days, people go back to work the next day. I mean, I tell them not to, you know, start making billion-dollar decisions about their lives or their companies if they're on some opiate narcotics. But, you know, you have to be careful, but you really don't have to.
What about for my pelvic pain patients, though, that are doing a lot of that, like, do we avoid twisting and, you know, activities like tennis and swimming and different things that require.
You mean in the initial post-op period in the first month? Yeah, you avoid that. But again, after a month, you know, I do, because I recognize that people go crazy when they're not doing anything. And both for their physical health and their mental health, I do try and get people back up and running quickly.
And also, I kind of feel like we're talking about patients who don't necessarily have concomitant like issues like endometriosis, or if we're just talking, So I feel like
if you have somebody who's a lot more complicated, has a lot more pain generators, has a nervous system that is just completely jacked up because of all the other things going on. From a structural viewpoint, I'm not telling them that they can't do things, but generally they're going to go a lot slower. And to be honest with you, it's not because of the structural integrity of the hernia repair. That still is a 2-month thing, but it's more because they're just in a lot more pain in the post-op period. And it may even be that the hernia repair revved things up from a pelvic floor dysfunction component. We irritated the nerves. So that's.
Would you say that's also for, like, let's say a male patient has had testicular pain for 4 years or 5 years, and they're super sensitized because of all of that pain. Would you say the same then for a patient who, like, would the recovery also be more elongated because of that?
No question. Yeah, no question. We may rev it up. They may come into the surgery with symptoms at a 2 or a 3, and we may rev up the symptoms to a 6, and they're not happy with us. But really, we talk about a 6-month window where this is going to be a bad 6 months, but it's going to turn around. And then really when the dust settles, that's when we're going to see if we've achieved something that was helpful for you, And those are the really complicated pain patients that have pain generators. If somebody's got pudendal neuropathy and they have a hernia at the same time, fixing the hernia isn't going to change the pudendal neuropathy, unfortunately. So we do want to talk about that with patients. We do want to make it clear that we want to give people hopefully relatively realistic expectations. But it just depends on how complicated the patient is, I think. And I think you and I see this all the time, where some patients bounce back and it's fabulous, and some patients really have a tough time. And I think it's more of a nervous system, not that they are nervous, but the system, their central nervous system is on hyper alert all the time. And that's due to whatever thing, whether it's pelvic floor dysfunction or endometriosis or chronic prostatitis or any one of these things that really is constantly making the nervous system on edge, so to speak. But sometimes what we'll do, and you've been great with this, is put them on preemptive nerve medication before surgery, because sometimes that is something that'll be helpful for the post-op period as well.
Yeah. I think a lot of people have a hard time understanding why, and unfortunately we don't have that many amazing drugs as options.
Yeah.
But they are there to kind of desensitize the way the brain, which is the central nervous system, the brain and spinal cord work, and to desensitize that pain. But yeah, like you said, it's very difficult to treat chronic pain, and a quick hernia repair is not going to be necessarily something that's going to solve someone's problems. And
right. It may just be one small part of an overall equation, but there's no question that when you have somebody and a lot of their symptoms are being generated from the hernia, by fixing the hernia, it is definitely an improvement for them. And I see that. I mean, I just talked to one of my patients today, and a lot of pelvic floor dysfunction symptoms. And really, he just had fairly significant inguinal hernias. We fixed them. A lot of these pelvic floor dysfunction symptoms are now gone. And I just think, it's all part of a bigger picture, but you won't know until you try. That's the other part. And I think I say that to patients, and I'm as serious as I can be about this. I don't know if this is going to solve your pain. I think it's worth a shot. I can't promise you the outcome because I don't know if this is a pain generator or not. I do think that structurally it's better not to have the hole in your body and something pushing through and irritating things. There's enough being irritated right now.
So I don't know, I'm not going to bring up a patient's name, but I had that patient that I had you look at imaging, and she had a history of endometriosis, long time, many, many years, in her late 50s, had multiple reasons not to have surgery, including some neurologic conditions, but ended up doing multiple inguinal injections, getting relief every time, would come back every 3 to 4 months for one because she would get relief. And finally, I thought, I convinced to get surgery, got the surgery, pain is gone. And she was thinking it's the endo and went on Orlissa, didn't want to have any endometriosis surgery. And, it's like, I told you, but you only want to be like, just try it. Just try the surgery. There's no reason for the injection to diagnostically help unless there's something there. So I think, I say literally give it a shot, give it a shot.
Right. And I say give it a shot by doing an operation.
Yeah, so it's a little different. All right. Well, I mean, I'm just going to ask you really quickly to mention, well, I wanted to ask if you fix diastasis recti when you're operating on patients, if that's something that you would do at the same time. And then if you could just mention sports hernias really quickly.
Sure. So diastasis recti means that the rectus muscles, which are the muscles that sort of go down the center and are either side of your belly button, they separate, they stretch out laterally. And that will happen when people gain a lot of weight, or unfortunately it happens with pregnancy, and the abdominal wall gets stretched out. And then unfortunately, when it gets stretched, it doesn't necessarily come back to the point where it had been prior. So there's this layer of fascia that was nice and tight and thick, and it was stretched out, and now it became thin and floppy. And you can definitely fix that. It's not technically a hernia, so unfortunately a lot of the insurance companies will say, well, that's more of a cosmetic maneuver, although it truly is a functional problem. And this is unfortunately insurance companies and how they get away with things, but they say, well, this is a cosmetic thing. You're going to have to pay for that on your own type of thing, or they don't cover it, or this, that, whatever. But I'm a big fan of fixing diastasis recti, mostly because there's a functional problem when you stretch the abdominal wall like that. So for all intents and purposes, to me, it acts like a hernia anyway. So I think it's very good to fix it if it's a significant factor in somebody's surgery. And we talk about it. You know, we talk about the pros and cons of doing it. You can separate out the abdominal components and put them back together and recreate the abdominal wall functionally. I do think that really helps people from a functional standpoint. Sports hernia is a very bad name to a problem that exists, and it doesn't have to happen to an athlete. It's not necessarily from sports, although that is the most common reason why it happens. And essentially the sports hernia is not a hernia, it's not an opening, it's a tearing of structures off of the pubic bone. And if that happens, it gives you a lot of symptoms that are similar to hernia symptoms, and that's why the term sports hernia came about back in the 80s or so. But that's also an area of my expertise, and the reason why is because just with the whole groin pain and the hernia stuff, it was a natural extension of what I was doing, and I was getting sent these patients who had these problems that they didn't have an actual hernia, they didn't have a defect, but they certainly had symptoms and signs on the MRI of a tearing of those structures. So we have developed operations in the last 20 years or so that really address the sports hernia problem. And to date, the data shows that if you have a legitimate sports hernia and you fix it, there's about an 85 to 95% success rate that you're going to get a good result.
So how does the patient present with a sports hernia versus compared differently?
So the pain from a sports hernia generally emanates from the pubic bone. And that is that bone that's kind of like right in the center. If you draw a line directly from your belly button right down to your genitalia, essentially, it's the bone on either side. And that bone that you can feel, that pubic bone, generally is the epicenter of the problem. People start feeling pain that's radiating outward. It radiates up the abdomen, sort of up the lateral rectus, and down into the adductor, which is in the inner thigh. It is that ropey tendon that when you do a frog stretch or when you do kind of like a groin stretch, you see that pop out. That thin tendon that's popping out is where people get pain, usually when they have a sports hernia. And the pain is not necessarily at the time that they're doing the activity, it's sometimes afterwards. So it's an extremely common problem or an extremely common complaint that somebody would say that they're able to play a full soccer game, but afterwards they are in a ton of pain. They can't get up off the bed. Their inner thigh is really hurting, or they're fine that night, but the next morning they're in a ton of pain. So there's almost this delayed pain that occurs after they play the sport. And that's part of the exam that you would end up doing.
A lot of patients are often, do you see it in pregnancy, postpartum?
You actually see that exact problem in pregnancy, but the difference is you don't fix it at that time. And the reason is, oftentimes with pregnancy, that will actually get better. And it'll probably get better because most people who have just delivered are not going out and playing 2 hours of tennis, for the next 4 or 5 months. Whereas the person, the female tennis player who is number 16 on the East Coast is playing 6 hours a day, and she's constantly wearing that attachment, so it never actually gets a chance to heal, and then it becomes this chronic separation. So the postpartum female we almost never fix, and we almost never have to fix, but the athlete or the person who's constantly doing something that's pulling at that structure and not letting it heal from the initial injury, that's the person that you end up fixing. Because after 6 months, they continue to have pain, they're not doing well, the imaging shows that they have some fluid in that area in specific spots, and you can offer them an operation, and generally they'll do very well.
And now, let's say you have this plus the other hernias. How does the recovery change?
Dramatically. So that'll double the recovery time, meaning the bottom line is that you're going to end up having a 4 to 6 month recovery, and there's going to be a very significant physical therapy component that'll last for about 3 months. And the reason why is because you're not just plugging a gap, you're reattaching structure to bone at the pubis. So that's a very different kind of maneuver, and therefore requires a very different and a much longer recovery period.
Yeah, I see that a lot. And I tell patients all the time that this is like minimum 6 months until the swelling goes down and everything starts to feel back to normal.
Right. You're talking about in your postpartum patients?
No. In your sports hernia patients.
Gotcha. Okay. Right. But if we try to get them better without surgery, and if they get better, we let it be. And if they don't get better, that's when there's a reasonable time to offer surgery. Every once in a while, you have a high performance athlete who makes a living from their sport that doesn't have 6 months to wait, and they'd rather do the surgery and have a 3 month turnaround time.
Yeah. Are you doing anything with the pudendal nerve officially?
So officially, we're offering an operation where you laparoscopically go in and release what's called the sacral spinous ligament to free up the pudendal nerve. There is some literature, and it's all very experimental. It's so early on in this part of this field, but the early data suggests that people get anywhere from 50 to 75% of a relief if they have true pudendal neuralgia, and you really have to make sure we diagnose that. They get relief when you release that ligament, and the reason is because we believe that the ligament there's compression on the nerve and possibly the vessels that go along with the nerve at that ligament spot. And if you release the ligament and you move the nerve and the artery and the vein out to in front of it, they do a lot better. So is it definitive that this is going to solve a pudendal neuralgia problem? No, but the early data is pretty good. On the other hand, it's still a surgery, and it's an experimental surgery, and it's early on in our knowledge base with it. So I don't have millions of people saying, I want that surgery, because it's early. It's very early.
Yeah, and pudendal neuralgia is not fun to have, so people have to be pretty desperate.
Right.
A lot of pain, unable to sit for long periods, just.
Right.
But
and if it can be managed otherwise, if it can be managed with medications, fabulous,
Yeah. All right. Well, I appreciate you taking the time to talk to me. I will.
My pleasure.
Save this onto my page and somehow figure out how to get this onto YouTube, and I'll share it with you whenever I figure that out. Thank you so much, and I hope if anyone else has any questions, they can reach out to Dr. Mark Zoland at his Instagram or on his website, which is, what's your website?
CoreSurgicalMD.com.
And are you doing telehealth visits?
Yeah, since COVID occurred, we're doing quite a few, and we're still doing out of town, out of country visits for these types of things all the time. And a lot of people are flying in to have surgery, so that's happening now a lot more often. So yeah, I'm very comfortable with the telehealth visits.
Oh, last question. Wondering how that release will then affect pelvic support.
Yeah, no, it's definitely a huge question that we do think about. The surgeon that has done the most of these is in Belgium, and I'm in contact with him, and he so far feels like it really hasn't been a significant factor. And the reason why is because, well, I don't know for sure the reason why, but we believe that the reason why is because there's a secondary ligament, the sacrotuberous ligament, which doesn't do exactly the same thing, certainly, but it is also a very powerful support structure that is there. And, you know, if you're talking about a miserable patient and you're looking to get rid of their pain syndrome, and then you're having to deal with that lack of support from the sacrospinous ligament being cut, I do think that as long as you have a real conversation with people about that, people, you know, can potentially opt for the surgery. The nice part is I don't think there's been some serious side effects to that issue.
Yeah. And I feel like with if they've been doing pelvic physical therapy before, hopefully they're prepped for it going in and then coming out as well. And I think that's like the really important thing, part of having a rehab team with patients getting checked out for hernias. You know, if they're already prepped, then, you know, they're already in tune with the whole team to take care of them.
Yeah. And I think the critical element here is just to be honest and to say, look, we don't know, you know, we can absolutely do the maneuvers. We hope that they'll give you relief. And sometimes at the end of the day, you just don't know until you try it and you're kind of rolling the dice. But the good news is that there's not a huge downside to doing the maneuvers. You know, it's not like we're doing brain surgery. We're not doing heart surgery. Mm-hmm. You know, in my hands doing it every day, it's a relatively low risk. It's not risk-free. It is surgery. But at the end of the day, it's, you know, there's not a big risk profile to these types of things.
Yeah. All right. Well, thank you again. And I will talk to you soon, I'm sure.
Yep, absolutely.